Thank you very much, Mr. Chairs. I'm sorry I was late. I was chairing a session downstairs. Okay, so over the next few minutes, 15 minutes, okay. I'd like to go through the importance of glycemic control in people with type 2 diabetes. These are my disclosures. So a few outline that I'll share with you now. In terms of the background, we know that beta cell function starts going down well before the diagnosis of diabetes. Often they say 50% of the beta cells have gone, but I think we're more proactive, so it's not as bad as it used to be. But then we see gradual decline in beta cell and eventually leading to use of insulin therapy. And we've seen this in UKPDS. Doesn't matter what intervention we use. So on the left-hand side, see conventional glibenclamide, metformin, insulin. We get initial reduction HbA1c and gradually goes up. On the right-hand side from UKPDS shows that majority will require additional drugs. So proportion of patients with an HbA1c less than 7% at 9 years was only 13%. So all of these people will require additional drugs. There's also a linear relationship with the HbA1c reduction and the benefits that we get. This is Irene Stratton's. So each 1% HbA1c, from going from 8% to 7%, you get all these benefits. Going from 70% to 6%, you still get all these exactly the same benefits. And these are reductions in microvascular complications, amputations, type 2 related death, acute myocardial infarction, and stroke. So wherever you're at point, it's beneficial. We have so many therapies now, and the reason we have so many therapies is not one single anti-hyperglycemic agent will address numerous pathophysiological defects that are related to type 2 diabetes. So we have so many in our armament that we should be really using them with their complementary modes of action. And this therapy should be individualized based on our known pathophysiological defects, and we need to use multiple therapies. In terms of evidence for early intervention, there's lots of evidence. This is the data from UKPDS Accord Advanced BADT showing reductions in HbA1c and leading to microvascular benefits in the early phase, and then even macrovascular and mortality benefits if you start very early from diagnosis, as UKPDS has shown. And UKPDS taught us about this glycemic legacy benefits, as you can see on the graph here. Conventional therapy and metformin, there's this pink line, and that's the glycemic benefits you get. And reducing that glycemic burden on a person with diabetes leads to longer term benefits. Even after the trial was finished, they continued getting the benefits post-trial monitoring, and this was called the legacy benefits. And now we have 24 post-trial data. I don't think there's any study that we know of has been going this long. So 44 years from when the trial was initiated. We saw benefits for microvascular outcomes in when the study was first reported in 1997, 2007, 10 years later, we had the myocardial infarction, significant benefits. And then now 2021, we see sustained benefits in terms of any diabetes-related endpoint, myocardial infarction, microvascular disease, and all-cause mortality, all significant, showing if we start from diagnosis, we can have all these benefits. We've also seen this in the STENO-2 study. This was a multifactorial randomized controlled trial in people with microalbuminuria and type 2 diabetes, where they reduced blood pressure, lipids, and cholesterol. And this was a remarkable study. This is a cardiovascular outcome trial with only 160 participants, 80 in the intervention arm, 80 in the control arm. Within 7 years, they saw microvascular benefits and kidney benefits. 8 years, they saw cardiovascular benefits in this small randomized controlled trial. There's lots of other data showing benefits for early glycemic control. This is looking at a systematic review of early insulin from diagnosis, giving people insulin, either multiple daily injections or continuous insulin. And this systematic review and meta-analysis showed that proportion of people drug-free and in remission was about 66% at 3 months, 60% at 6 months, and 40% at 24 months. So giving that initial therapy, and usually this was between 1 to 3 weeks only, reduce the hyperglycemic burden on the beta cells, rest them, and you get the long-term benefits. We've seen this in other randomized control trials. This is a randomized control trial of newly diagnosed people with type 2 diabetes. On the left-hand side, you can see HbA1c from 11% comes down to 6%, and it remains so for 4 years. Remarkable. We say it's a progressive disease, but if we start early, we can get the HbA1c down, and it will stay so for a longer period. And on the right-hand side, we see, in terms of C-peptides, there's improvement in beta cell function as well if we go in early. This is a typical Ralph DiFronzo study, a randomized control trial from diagnosis, triple therapy straight away, or staged approach like we do, stepwise approach, 1 therapy, 2 therapy, 3 therapy, but they were still aggressive in this stepwise approach. As soon as the HbA1c was above 6.5, they put the second therapy and then the third therapy. And we see again here, HbA1c comes down from 9% to 6% from diagnosis with triple therapy, and it remains so for 4 years. On the right-hand side, the Kaplan-Meier curve showing the separation very, very early on in the proportion of people reaching a target of less than 6.5%. In that study, in the intervention arm, despite going down to HbA1c at 6.5% very early, they did not have as many hypoglycemia as the conventional arm. This is a study we conducted using 5 databases, 4 databases in Europe and 1 in US. And this was a nice study showing a simple message. If you get people down to target at 3 months, they're more likely to remain target at 24 months below HbA1c of 7%. So that's a simple thing to remember. Get them to target and they'll remain on target for a longer term. And this is the STENO2 I mentioned about the myocardial infarction benefits. Well, this has now 21-year data. And in this study, we saw at 21 years, 70% reduction in heart failure, 70% reduction in stroke. But the most important thing, there were 8 years of life gained. 8 years, extra life years for people who had multiple risk factor control. And we talk about legacy benefits for glycemic control. Well, there's legacy benefits for all the other risk factor controls. So now glucose control, we've got 27-year data from UKPDS. Blood pressure control, there's 10-year data. Lipid control, 18-year data. And multiple risk factor control, as I showed you, 21-year data. So legacy benefits for all risk factors, not just for glycemic control. This is a meta-analysis that we've just conducted of 12 randomized control trials of early glycemic control. And what we see in this is about a 16% reduction in risk of microvascular outcomes. Microvascular outcomes, 12% reduction in risk, mainly driven by retinopathy, 15% relative risk reduction, again significant for microvascular outcomes and retinopathy here. And nephropathy, there was also about a 30% relative risk. What do the guidelines tell us? Well, guidelines tell us that we should be using, on the left-hand side, organ protective therapies, SGLT2s, GLP-1 receptor agonists. That's 30% of the population. On the right-hand side, those without cardiovascular disease, we can bear enough use of anything. This is a question I ask at every meeting. How many of you have seen this? This one? Everyone? Yeah. How many can tell me what the blue circle is? No one. Okay. To me, that's the most important thing. And I'll tell you about that shortly. We live in a society that doesn't have abundance of funding and money and out-of-pocket money. Out-of-pocket monetary use is very, very common, especially in countries like India. And so the ADA guidelines, which I was fortunate enough to be part of, says that we should think about the cost-related barriers and consider the low-cost medications that are so available in India particularly. The other important thing is you know all the results of the cardiovascular outcome trial. Xavi's just mentioned about SGLT2 inhibitors, but even in the organ protective cardiovascular outcome trials with SGLT2 inhibitors, GLP-1 receptor agonists, we see a reduction which is greater if the HbA1c reduction is greater in the trial. So despite having these therapies, if you get HbA1c lower than it is, you get benefits. So there are benefits irrespective of the therapy you use. So efficacy to effectiveness gap, this is where we know what we should be doing, but we're not doing it. It doesn't translate into clinical practice. And for example, the Discover study is the largest study, prospective study we conducted of 33 countries. And what we see is HbA1c is really high when we start second line therapy. People had diabetes for 6 years, 7 years before we start second line therapy, and HbA1cs are over 8%. Just not good enough despite all the evidence that we have. So I'm gone really fast, I hope, faster than I should have done. So, in summary, type 2 diabetes is a progressive disease. Early preventative actions and tight glycemic control, including all the other risk factor control, will lead to longer term benefits. Therapy must be started early, and we should say therapy should be started in combination therapy from day one, get go, as soon as a person has diabetes, to prevent progressive beta cell loss. And appropriate patients will require different combinations of therapy depending on that phenotype that's sitting in front of us. And there are a number of other interventions we haven't talked about that can reduce glycemic control, as well as diet and exercise as well. The key really is to individualize our therapies and our interventions to that person in front of us. Thank you very much for listening.